Hello everyone. In this module, we are going to discuss a very important entity, often the hot favorite for examiners out of all the valvular heart diseases, that is mitral stenosis. Okay, let's discuss mitral stenosis. Mitral stenosis. All right. So we'll be discussing this in various subheadings. To begin with, let's discuss the etiology of mitral stenosis. Okay, let's discuss the etiology of mitral stenosis. So mitral stenosis, the most common cause of mitral stenosis is rheumatic fever. Very important. The most common cause is going to be rheumatic fever. Okay, that is the most common etiology. Now, when you talk of, say, rheumatic heart diseases, a pure MS or a predominant MS. Predominant MS means you might be having an associated valvular disease like a MR also, mitral regurgitation also, but the predominant lesion will be MS. So one point you have got to note is that pure or predominant MS, this occurs in almost 40% cases of rheumatic heart disease. So almost 40% cases of rheumatic heart disease, you can see a pure or predominant mitral stenosis. And if you take rheumatic MS as a whole, almost 2/3 of patients with rheumatic MS, they are females. Okay, so 2/3 of rheumatic MS, 2/3 of rheumatic MS, they occur in females. Okay, 2/3 occur in females. So I told you the most important entity or the most important etiology of mitral stenosis is rheumatic fever. Is rheumatic fever the only etiology associated with mitral stenosis? No. There are other etiologies also associated. So let's have a look at what are the other etiologies associated with mitral stenosis. Okay, other etiologies associated with mitral stenosis. You can have a congenital condition which is known as congenital mitral stenosis. Okay, there is a condition by name congenital mitral valve stenosis. So this is obviously not related to the rheumatic fever, it is a congenital condition. Then you can have a mitral annular calcification which can extend to the leaflets. Okay, so a mitral annular calcification extending to the leaflets can also cause a mitral stenosis. Okay, extending to leaflets can also cause mitral stenosis. Third, there is an entity by name core triatriatum. Okay, what is it? Core triatriatum. So what is this core triatriatum? So triatriatum, which means there is 3 atria. So what happens here is there is actually a thin membrane or further divide the LA or RA, subsequently resulting in almost like appearance of 3 atrial chambers, which is called a triatriatum. Okay, which is another possible etiology for mitral stenosis. You can have MS associated with conditions like left atrial myxoma. Okay, left atrial myxoma leading on to a stenosis. Okay, that can also cause a mitral stenosis. Then conditions affecting connective tissue like rheumatoid arthritis, even systemic lupus erythematosus can also lead on to mitral stenosis. And also, when you have IE, infective endocarditis, and large vegetations which can again cause obstruction of the flow, that can also lead on to stenosis across the mitral valve. So, infective endocarditis with large vegetations. Okay, infective endocarditis with large vegetations. So these are the etiologies for mitral stenosis, but remember, the most important etiology that you have to think of always is rheumatic fever. Okay, so I hope you are clear with the etiologies. All right. Okay, let's now go and discuss the pathology of rheumatic MS. Okay, let's discuss the pathology of rheumatic MS, pathology of rheumatic mitral stenosis. So what actually happens as a result of the disease process? Well, the cardinal features of rheumatic MS, let's just see them. What are the cardinal features of rheumatic MS? So you can have a thickening of the leaflet edges. Okay, you can have a thickening at leaflet edges, that is the edges of the mitral valve. You can have a commissural fusion. Okay, the valve commissures can get fused, so there can be a fusion of valve commissures, which is number 2. And you remember about the chordae tendineae that I discussed. So there can be a chordae tendineae affection. What sort of affection? There can be a shortening of the chordae tendineae and again a fusion of the chordae tendineae as well. So these are certain cardinal features of rheumatic MS. Going a bit more into the depth. See, the disease process actually begins with an acute rheumatic fever, correct? So let's see what happens during acute rheumatic fever and what are the changes that happen as the disease progresses. Okay, so in case of acute rheumatic fever, let's see what happens. So in case of acute rheumatic fever, in that acute stage, there is inflammation and edema occurring at the valve leaflets. Okay, there is inflammation and edema of valve leaflets. Okay, that is number 1. And also you can have at the leaflet contact zones, you can have small platelet fibrin thrombi. Okay, so you can have platelet fibrin thrombi. Okay, you can have platelet fibrin thrombi along the leaflet contact zones. Okay, along the leaflet contact zones, you can have platelet fibrin thrombi. Remember, this is what happens during the acute stage. Subsequently, what happens is there can be a scarring. Okay, subsequent scarring occurs. So what happens is the disease process proceeds. There can be a valve deformity. Okay, and the leaflet architecture is actually obscured by the fibrosis disease process that is happening. So there is a disruption of leaflet architecture. there is a disruption of the leaflet architecture, and there can be neovascularization. There can be neovascularization also happening. Neovascularization, and so there is new formation of new blood vessels, and there is again connective tissue change also. There is increased collagen and tissue cellularity as well. Okay, there is increased collagen, so there is a collagenization, and there is an increase in the tissue cellularity. Okay, increase in the tissue cellularity. Okay, so this is what happens, and subsequently as the disease goes on and on, what happens is the valve turns out to have a funnel shaped or sometimes almost a fish mouth shaped. Okay, so in the end stages you can have a funnel shaped valve or a fish mouth shaped valve. Okay, funnel shaped or a fish mouth shaped valve you can see. And also the stenotic mitral valve can undergo calcification, and whenever there is a calcification, what will happen to the mobility of the valve? There will be an immobilization of the valve, and subsequently this will narrow the orifice again. Okay, this immobilization will again narrow the orifice. So there can be a calcification. There can be a calcification of the stenotic mitral leaflet, subsequently again immobilizing the valve, which again, it will accentuate the stenosis. Okay, that is very, very clear. So that is about the disease pathology. Okay, all right. So after having learned regarding the disease pathology, let's now move on to the pathophysiology of the disease process. So for a clinician, this is very, very important. Okay, so what is the pathophysiology of mitral stenosis? What is the pathophysiology of mitral stenosis is what we are going to learn. Now, talking about the pathophysiology of mitral stenosis, a very, very important terminology that you have got to understand, which will help you in assessing the severity of the mitral valve obstruction. So that terminology is related to the degree of valve opening in diastole, and that terminology is the mitral valve orifice area. Okay, mitral valve orifice area, very, very important. Okay, mitral valve orifice area. All right. Now, when you talk of the normal adults, okay, when you talk of normal adults, the mitral valve orifice area is around 4 to 6 centimeters square. Okay, this is around 4 to 6 centimeters square, that is in normal adults. Okay, so when this orifice is actually reduced, and say when it becomes around 2 centimeters square by around 2 centimeters square, you call it mild MS. Okay, you call it mild mitral stenosis when the valve orifice area almost is around 2 centimeters square. So at this stage of mild MS or a mild mitral stenosis, you can have the blood flowing from LA to LV, but since there is a stenosis, this flow needs to be propelled by some degree of pressure gradient, okay, which is important. So that is what you have got to understand. Okay, so the patient begins to have some early symptoms, and what are the symptoms? We will be coming to that in due course of the discussion. Now, when the mitral valve orifice again narrows, this can go on to a stage of severe MS. Okay, this can go on to a stage of severe mitral stenosis. So the value of this severe MS is slightly given differently in different references. Some textbooks give 1 centimeter square, some textbooks give 1.5 centimeter square, but I am taking 1.5 centimeter square because the treatment aspects is also slightly related to this. So severe MS is 1.5 centimeter square. So if it is less than 1.5 centimeter square, you call it a severe mitral stenosis. But when it comes to a stage of severe MS, okay, in this stage of severe mitral stenosis, what happens is that the left atrioventricular pressure gradient is approximately around 20 millimeter mercury. That is the gradient that is required for a forward propulsion of blood. So as to maintain a normal cardiac output at a stage of severe MS, you have got to have a left AV pressure gradient, of around 20 millimeter mercury. Okay, so at this stage, say with a normal LV diastolic pressure, the LA pressure will be slightly more than 25 millimeter mercury. But I hope by now you understood that a larger pressure gradient is required for the forward flow of blood. Okay, so the LA pressure actually increases. Agreed, no? Now what is the consequence of LA pressure? We are learning the pathophysiology and we are trying to understand what will happen once the LA pressure increases. So let's try to see the consequence of increased LA pressure. Okay, the consequence of increased LA pressure is what we are going to learn. So what happens is, when there is an elevated LA pressure, obviously you tell me what will happen to the pressure in the pulmonary veins. There will be a rise in the pressure in the pulmonary veins, correct, no? Or I can say that there is a pulmonary venous hypertension. Pulmonary venous hypertension. So there occurs a pulmonary venous hypertension. So why is there a pulmonary venous hypertension? You see, the pulmonary veins are draining into the left atrium, and obviously when the LA pressure increases, there can be pulmonary venous hypertension. Now this pulmonary venous hypertension, what it can lead on to is that this can lead on to a pulmonary capillary hypertension and a subsequent pulmonary arterial hypertension. Okay, so there can be a leading on to a pulmonary capillary hypertension and a pulmonary arterial hypertension. So you can have a PAH that is developing. Okay, and when you have a pulmonary arterial hypertension, obviously you are going to have an affection of the right side of the heart. So you can have an RV dilatation and an RV failure. Okay, so you can have an RV dilatation and failure, and this RV dilatation, well, this can also lead on to secondary tricuspid regurgitation. Okay, a secondary tricuspid regurgitation. So you may or may not have an associated TR. Okay, but that is always a possibility. Okay, so can I summarize whatever I have said so far in the pathophysiology here? Let me just try to summarize. So the summary is, there is a elevated LA pressure, which is the fundamental hemodynamic abnormality. Elevated LA pressure is the fundamental hemodynamic abnormality. Okay, elevated LA pressure. So that is going to be the fundamental normality. Subsequently, there is an increase in the pulmonary venous pressure, increase in the pulmonary capillary pressure, yes, increase in the pulmonary venous and capillary pressures. This can even lead on to pulmonary arterial hypertension, and subsequently, the patient can experience symptoms like an exertional dyspnea. Okay, this is the summary of the hemodynamic changes that occurs in case of mitral stenosis. Okay, now there are certain triggers which can lead on to, say, a decompensation of a mitral stenosis. So there can be certain triggers. You've got to understand the triggers, because often in a patient who is having a compensated mitral stenosis, it is the triggers that actually lead on to worsening of the condition. So what are the common triggers? One is exercise. Okay, so the demand is more exercise. You can have anemia, you can have pregnancy, you can have conditions like thyrotoxicosis. Okay, all this can lead on to triggers or worsening of mitral stenosis, decompensation of mitral stenosis. Even if you get some infections also, maybe some pneumonia, okay, so infections also can lead on to decompensation. And even very, very importantly, I'm writing with a different ink, atrial fibrillation. Okay, atrial fibrillation can also lead on to a decompensation in mitral stenosis. So these are all the triggers. Now the question is, how do they act as trigger? Well, these conditions, what it can do is that this can actually increase the rate of blood flow across the mitral valve orifice. Okay, so how do they trigger? So they either can increase the rate of blood flow, across the mitral valve orifice. Okay, and this will actually further elevate the left atrial pressure. Okay, so this will increase the LA pressure, which is very important to understand. And also there will be a decrease in the diastolic filling time. Okay, there will be a decrease in the diastolic filling time, which is also important to understand. And this results in a decrease in the cardiac output. Okay, there is a decrease in the cardiac output as the disease progresses. There can be when there is a significant or a severe mitral stenosis, the forward cardiac output is also decreased. So basically what I am trying to tell you is that majority of the clinical manifestations of mitral stenosis is the result of a higher transmitral gradient. Okay, the gradient across the mitral valve, a higher transmitral gradient plus an inadequate LV filling. Okay, inadequate LV filling. So this is responsible for majority of the manifestations of mitral stenosis. Okay, and one more point you have got to know with respect to the hemodynamics of mitral stenosis. Well, you can have atrial fibrillation developing in patients with mitral stenosis as a common complication. So obviously the question is, AF in mitral stenosis, why does this occur? Why does AF develop in MS? There are multiple reasons which are probably attributed to the development of atrial fibrillation in the case of mitral stenosis. One is the LA dilatation, okay, left atrial dilatation, and subsequently you can have a fibrosis of the LA wall, left atrial wall fibrosis, yes. And what happens as a result of this disease process is there can be a total disorganization of the atrial muscle fibers. Okay, there can be a disorganization of atrial atrial muscle fibers. Disorganization of the atrial muscle fibers. So this is actually what happens. Now once the AF is actually established, okay, suppose you have got a established AF, then what happens is, once AF is established, there is a higher likelihood of what? Hemodynamic deterioration in case of MS. There is a chance of hemodynamic deterioration. Okay. So why does this hemodynamic deterioration happen? Is because there is an impaired LA contractility. There is an impaired LA, left atrial contractility happens. Okay. So because there is a decreased LA contractility, there can be a decreased LV filling and a reduced cardiac output. Okay. So there is a decrease in the cardiac output as well. And very, very importantly, whenever you have an atrial fibrillation, that can actually lead on to a thrombus formation, because you will have a, the atria is not contracting in a coordinated manner. So the circulation also becomes sluggish. So the AF can predispose to thrombus formation. This can predispose to thrombus formation, which is also very, very important to understand. So this is in a nutshell about the the pathophysiology and hemodynamics of mitral stenosis. I hope this much is very clear. All right. Okay. Let's now move forward and discuss the clinical presentation of mitral stenosis. Okay. Let's discuss the clinical presentation of mitral stenosis. So clinical presentation of mitral stenosis. First point you have got to note is that the interval between the initial actual episode of the rheumatic fever and the clinical evidence of mitral stenosis resulting in a mitral valve obstruction. So that interval actually ranges from a few years, sometimes 4 or 5 years, to up to more than 20 years. So there is a variability in this lag period ranging from say a few years to more than 20 years sometimes. Okay. And when you talk of the clinical features of mitral stenosis, often the early clinical features of mitral stenosis include, number 1 is dyspnea. Okay. Number 2 is fatigue. Okay. And number 3, you can have decreased exercise tolerance. Okay. Decreased exercise tolerance. So these will be the early symptoms of mitral stenosis. Okay. So when you have dyspnea, okay, so the dyspnea, the patient, often this might be associated with cough as well. You can even have cough as well and maybe wheezing also. And very importantly, please understand that the vital capacity is actually reduced. Vital capacity is reduced in case of mitral stenosis. So the vital capacity, if you ask me, why is the vital capacity reduced in MS? One is because of the presence of engorged pulmonary vessels. Okay, the presence of engorged pulmonary vessels. Okay, and also you can have interstitial edema as well contributing. Okay, you can have interstitial edema as well contributing. Okay, and as the disease progresses, once a severe MS develops or once a critical stenosis develops, okay, once a critical stenosis develops, it actually can lead on to orthopnea. Okay, it can lead on to orthopnea, and pulmonary edema. Okay, it can lead on to orthopnea and pulmonary edema. Okay, and remember, I again reiterate the factors that precipitates the decompensation of MS. So whenever you have conditions, say exercise, pregnancy, anemia, thyrotoxicosis, fever, development of atrial fibrillation or any other tachyarrhythmia, so all this can lead on to decompensation in case of mitral stenosis. Okay. As mitral stenosis, the disease progresses, when you have an increase in the pulmonary vascular resistance, okay, whenever there is an increase in the pulmonary vascular resistance, let's see what happens. Whenever there is an increase in the pulmonary vascular resistance, obviously you can have what? RV dysfunction, right ventricular dysfunction, because of which the patient can go on to develop signs and symptoms of right-sided heart failure. Okay, so begins as a left-sided disease but can eventually lead on to a right-sided problem also. So the patient can eventually in the disease process go on to develop, say, edema. You can have hepatomegaly. Okay, hepatomegaly. You can have ascites, and you can also have hydrothorax developing. Okay, so you can have right-sided features as well. Okay, important. The next clinical feature of mitral stenosis that you should know, again is very important, is hemoptysis. Okay, is hemoptysis. So about hemoptysis, hemoptysis in mitral stenosis occurs because of the rupture of the thin-walled dilated bronchial veins. Okay, it occurs because of rupture of thin-walled dilated bronchial veins. Yes, occurs because of rupture of thin-walled dilated bronchial veins. And why do these bronchial veins rupture? It is because of a rise in the LA pressure. So the increase in LA pressure is going to lead on to the rupture of the vessels. Okay, and the severity of hemoptysis in case of mitral stenosis actually varies. You can have a patient, who has just streaks of blood-stained sputum associated with, say, some features of, orthopnea, to a massive hemoptysis. Okay, so the degree of hemoptysis in case of mitral stenosis can vary. And in patients who go on to develop an acute pulmonary edema, okay, the patients, because of the increased pressure, they can go on to develop an acute pulmonary edema. So, in those patients, there can be rupture of the alveolar capillaries. Okay, what happens is, in such patients, you can have rupture of the pulmonary alveolar capillaries. Rupture of pulmonary alveolar capillaries, and that results in what? It results in a pink frothy sputum. Okay, this results in a pink frothy sputum. Okay, so this hemoptysis in case of mitral stenosis, well, this may also happen because of pulmonary infarction. Okay, though slightly rarely, there can be a rare development of a pulmonary infarction, and this pulmonary infarction can also lead on to hemoptysis. This is often a late complication of mitral stenosis. Once this has gone into the stage of a heart failure, that is when you can have a pulmonary infarction. And there is another rare symptom, a symptom that can raise your eyebrows, is the occasional presence of chest pain in patients with MS. Occasional chest pain in patients with MS. Let me tell you, this is not at all a classical or a prototype MS symptom. Okay, this is just seen in around 15% of MS patients may have some degree of chest pain. Well, what is the exact reason of the chest pain is not known. There are certain possible reasons. It is thought that this might be because of a severe RV hypertension. Okay, I'm just saying the possible etiologies. So one is a severe RV hypertension. The RV systolic pressure is actually increasing. So a severe RV hypertension secondary to a pulmonary vascular disease, that can result in a severe RV hypertension that can lead on to a strain and a chest pain. And sometimes you can have a coronary embolization. I told you there is a thrombus formation, and there is also a small potential that there can be a coronary embolization of these small clots. Coronary embolization. So that also can lead on to a chest pain. And also sometimes, MS, can present in the middle-aged individuals. So there is also a good chance that there can be a coexistent coronary atherosclerosis, which may also have contributed, and this is just a chance finding. Okay, so a coexistent coronary atherosclerosis. These are some of the reasons. Well, you don't learn this chest pain as a prototype symptom. That is what I want to tell you. This is often a rare symptom, and you're still not sure on the exact cause of chest pain in patients with mitral stenosis. Okay, all right. And patients with the mitral stenosis can go on to develop palpitations and embolic events. Okay, they can go on to develop palpitations and embolic events. So you can easily guess what sort of individuals actually go on to develop. So that is individuals with mitral stenosis and atrial fibrillation. Okay, so that can trigger embolic events. And another rare manifestation, another very rare manifestation of MS. Okay, remember, rare manifestations are always rare, so never quote them as the first manifestation or early manifestation. So the rare manifestation is that this can actually lead on. There is an increased LA pressure, there is a dilated left atrium, and there is a dilated pulmonary artery. Subsequently, what this can result is a dilated LA and dilated pulmonary artery can be there, and this can result in a compression of the left recurrent laryngeal nerve. Okay, so there can be a compression of left recurrent laryngeal nerve. Okay, compression of the left recurrent laryngeal nerve, and this can lead on to what? This can lead on to hoarseness of voice. This can lead on to hoarseness of voice, and this is referred to as Ortner syndrome. Okay, this is referred to as the Ortner syndrome. Okay, so these are the spectrum of clinical manifestations of mitral stenosis. Again, clear? Okay, let's move forward and let's discuss the examination findings. Okay, what are the examination findings in patients with mitral stenosis? Examination findings. All right. So the examination findings, number one, the pulse volume in patients with mitral stenosis. Let's go in an order. Okay. So the pulse volume, in majority of the MS patients and especially the early MS patients, usually the pulse volume is normal. Okay, normal. However, as the disease progresses, you can go on to develop a low volume pulse. Okay, So low volume pulse usually is seen with a severe mitral stenosis. So when there is a severe mitral stenosis, when there is a reduction of the stroke volume, there is a chance that there is a low volume pulse, and also associated with the development of pulmonary arterial hypertension, and also when there is a mitral stenosis which is decompensated maybe by some infection and subsequently leading on to a cardiac failure, also you can have a low volume pulse. And another abnormality with respect to pulse which nobody should ever forget is you can have development of irregular pulse, that is when the patient has atrial fibrillation. Okay, you can have a irregular pulse. Okay, irregular pulse. That's also clear? Yes. Now let's move on to the blood pressure. What happens to the BP? Okay, what happens to the blood pressure? So blood pressure in case of mitral stenosis is again usually normal. But there can be certain scenarios where you can have a narrow pulse pressure. Okay, narrow pulse pressure in mitral stenosis. So what are those scenarios where you can have a narrow pulse pressure? One is cardiac failure. Cardiac failure, you can have a narrow pulse pressure. When there is a pulmonary arterial hypertension, you can have a narrow pulse pressure. Okay, but otherwise in majority of the individuals, the blood pressure is actually normal. Okay, clear. Moving on to the JVP. Okay, JVP. So the JVP again in majority of the cases and in mild MS, this can be normal. This may be normal. Okay, but in patients with sinus rhythm, okay, the patients in whom you are having a pulmonary arterial hypertension and maybe a RVH developing, in such individuals you are having a prominent A wave. Why did I specifically say sinus rhythm? It will be clear in just a short while. So patients with sinus rhythm going on to develop a PAH and RVH, you can have a prominent A wave. And when there is a RV failure, okay, when there is an RV failure and maybe a tricuspid regurgitation also developing, you can definitely have a raised JVP. Okay, you can definitely have a raised JVP. However, if there is a atrial fibrillation, remember now the patient is not in sinus rhythm. Suppose you are having a AF that is developing. Okay, in such a case, very importantly, the most important JVP finding is the absent A wave. There is absent A wave. Okay, so pulse, BP, JVP, very clear. Okay, let's move on to what happens to the apex beat. What happens to the apex beat? So apex beat, classically you have the tapping apex in case of MS. Okay, there is a tapping apex in case of mitral stenosis. And in some patients, you can also have a diastolic thrill. Okay, some patients you can have a diastolic thrill. That is especially in the left lateral recumbent position, you can have a diastolic thrill developing. Okay, or you can feel the diastolic thrill. And in patients who go on to develop a pulmonary arterial hypertension, two very important palpatory findings are, number one, you can have a left parasternal heave. Okay, you can have a left parasternal heave, and also you can have a palpable P2. Okay, you can have a palpable P2. Okay, so you're clear with pulse, BP, JVP, apex beat. Okay, the palpatory findings. Very important. Now we are going to the auscultatory features. Okay, auscultatory features of mitral stenosis. Auscultatory features. It's very important to understand the very important auscultatory features of mitral stenosis include: one is a loud S1, important. Second, very important, mid diastolic murmur. Mid diastolic murmur. And number 3, opening snap. Number 3, opening snap. These are the important auscultatory features in case of mitral stenosis. Okay, but you will have to know the auscultatory features in detail. So let's discuss them individually. Okay, first coming to loud S1 in case of mitral stenosis. Okay, loud S1. First of all, why does loud S1 occur in mitral stenosis? Okay, why does loud S1 occur? Well, loud S1 is actually an indicator of the rapidity with which, okay, the pressure actually rises at the time of mitral valve closure. Okay, or you can say the wide closing excursion of the leaflets. Okay, the wide closing excursion of the leaflets is responsible for the loud S1. We have already seen this in the module on the heart sounds. Okay, so again it is indicative of the rapidity with which the LV pressure is actually rising at the time of mitral valve closure. Though I said this, don't think that all cases with mitral stenosis can have loud S1. Okay, so can you have patients with mitral stenosis without loud S1? It is possible. How? See, when there is a marked calcification. So when there is a calcification and thickening of the mitral valve leaflet. So when there is a calcification and thickening of the mitral valve leaflet, what can result is there can be a reduction in the loudness of S1. Okay, so there is a reduction in the loudness of S1. Okay, reduction in the loudness of S1. So why does this reduction in the loudness of S1 happen when there is a calcification and thickening? Because mobility is affected. There is a decreased mobility or a motion of the leaflet that is actually resulting in a decrease in the loudness of S1. There is a decreased closure. Okay, and you don't have the wide closing exertion. So that is what actually happens. Alright, now in addition to this, okay, one thing I told you, mobility restriction is responsible for a soft S1. So what are the other causes of soft S1? Other causes of soft S1 in MS. Okay, other causes of soft S1 in MS, that is what we are going to learn. That is when, number 1, there is an associated mitral regurgitation, associated MR. And if there is an associated aortic valve disease, which may be a AR or maybe even a atrial aortic stenosis. Okay, either aortic regurgitation or aortic stenosis, this can also result in a soft S1. Because I told you, you can have a multivalvular heart disease coexisting. So when there is an associated MR, you can have a relatively soft S1, associated AR, AS, you can have soft S1. So basically the loudness of S1 is related to the mobility of the mitral leaflets. It's not having a loudness of S1 is not directly related to the severity of MS. So please understand the loudness, okay, of the first heart sound, okay, is related to mobility of valve leaflets. Okay, is related to the mobility of valve leaflets. It's not at all. Very, very important. This is very, very important to know. It is not related to severity. Okay. So don't think that a louder S1 means a more severe S1. So the loudness is having no relation to the severity of MS. Okay. Very clear. So first auscultatory finding, we are quite clear with this. Let's go to the next one, that is mid-diastolic murmur. Okay, let's move on to mid-diastolic murmur in mitral stenosis. Mid-diastolic murmur. Well, the mid-diastolic murmur, again, very, very important auscultatory finding. Let's first see what are the features of this mid-diastolic murmur in MS. First point, it is a diastolic murmur, which is quite obvious. So it is a diastolic, low-pitched, rumbling murmur. Okay, diastolic, low-pitched, rumbling murmur. Okay, and this is best heard at apex. This is best heard at apex. And is this better heard with the diaphragm or the bell of the stethoscope? This is best heard with the bell of the stethoscope. Okay, this is best heard with the bell of the stethoscope. And what should be the ideal position of the patient? The patient should be in the left lateral recumbent position. Okay, patient should be in the left lateral recumbent position. Okay, very important. And one another point about the MDM or mid-diastolic murmur is that the duration of MDM, okay, the duration of MDM is actually related to the severity of MS. Okay, duration is related to severity in MS. But remember, I said duration, and remember, it is not, okay, it is not the loudness, not the loudness of MDM. The duration of the mid-diastolic murmur is related to the severity of MS, okay, which is again very important to know. So longer duration, it is again indicative of a more severe disease. Okay, now can you have scenarios where the MDM is absent in MS? That is what we are going to see. What about absent MDM in MS? Is it possible? Absent MDM in MS? Well, it is possible. One scenario is when you have a severe MS which goes to a state of a severe silent mitral stenosis. A severe silent mitral stenosis means the mitral stenosis is such that there is very severe stenosis and the transmitral flow is very low so as to produce a murmur. That is called a severe silent MS. And also in case of a severe cardiac failure also you can have a absent MDM. Okay, and maybe in individuals who are having emphysematous chest, sometimes the auscultation can be difficult. Auscultation of the MDM can be difficult when you have a emphysema or maybe an obese individual. These are the conditions you might not get an MDM in case of MS. Another term you have got to note is the pre-systolic accentuation of MDM. Pre-systolic accentuation of MDM is another term that you have got to know. Now, what is this pre-systolic accentuation of MDM? It means just before the systole, there is an increase in the loudness of murmur. Okay, so basically it is an increase in the loudness of murmur when just before systole. Okay, just before systole, which is why it is called a pre-systolic accentuation. Now this pre-systolic accentuation is actually a feature of rheumatic MS. This is actually a feature of rheumatic MS, and this is not common in other causes of MDM. Okay, we'll soon see what are the other causes of MDM, but please understand the pre-systolic accentuation is a feature of rheumatic MS. Now you might ask me, why does this happen? Why does this pre-systolic accentuation happen? Well, this happens because of atrial contraction. Okay, why does this happen? It happens because of atrial contraction. Okay, so when there is an atrial contraction just before the ventricular systole, what happens is that this atrial contraction will increase the rate of blood flow across a stenosed mitral valve. And this atrial contraction resulting in an increased rate of blood flow across a stenosed mitral valve is responsible for the pre-systolic accentuation. And you now tell me what will happen if the individual is having an atrial fibrillation. Will this atrial contraction happen? No. So will there be any pre-systolic accentuation? No. So which means if you have atrial fibrillation, there is absent pre-systolic accentuation. Okay, there is absent pre-systolic accentuation. Okay, very important. Now let's see what are the other causes of a mid-diastolic murmur, that is other than mitral stenosis. Okay, other causes of MDM. All right. Number one, you have the Carey-Coombs murmur. Okay, what is it? You have the Carey-Coombs murmur. So this Carey-Coombs murmur is a murmur that is related to an acute rheumatic fever. Okay, remember I am not talking of rheumatic heart disease, I am talking of an acute rheumatic fever. You can have a mid-diastolic murmur, which is the Carey-Coombs murmur. Then you can have an increased flow, murmur, MDM, when there is an increased flow across a non-stenotic mitral valve. That there is no stenosis, but the increased flow is actually resulting in an MDM. Okay, so increased flow across non-stenotic mitral valve, across a non-stenotic mitral valve. So this happens as in conditions like large ventricular septal defect, a patent ductus arteriosus, as well as a severe mitral regurgitation. Okay, large VSD, PDA and severe MR. It can also result in conditions where there is an increased flow across a non-stenotic tricuspid valve. Okay, even there you can have a mid-diastolic murmur. So increased flow across non-stenotic tricuspid valve. Non-stenotic tricuspid valve, as in conditions like a large atrial septal defect and a severe tricuspid regurgitation. Okay, and the next condition that can result in a mid-diastolic murmur is a severe aortic regurgitation. So severe aortic regurgitation, well, what is the name of the murmur? It is an Austin-Flint murmur. Okay, Austin-Flint murmur, okay, of severe AR, and also in conditions like atrial myxoma. Atrial myxoma also you can have mid-diastolic murmur. So these are the conditions. Carey-Coombs murmur, okay, Carey-Coombs murmur, increased flow across the non-stenotic mitral valve, increased flow across the non-stenotic tricuspid valve, severe AR, atrial myxoma, important causes of MDM other than MS. Okay, so that MDM part is also clear for you. Now let's move forward and discuss the next auscultatory finding, that is the opening snap of the mitral valve. Okay, opening snap of mitral valve. Opening snap of mitral valve. Okay, so what is this opening snap? How is it caused? You have got to know it. Well, this opening snap is actually caused because of the sudden tensing of the valve leaflets. Okay, it occurs because of sudden tensing of valve leaflets. Sudden tensing of valve leaflets. When does it occur? It occurs after the valve cusp has completed their opening excursion. So after the valve cusp, okay, after the valve cusp has stopped or completed their opening excursion, okay, then there is a sudden tensing of the leaflets leading on to a opening snap. Okay, leading on to opening snap. So this opening snap actually occurs when the movement of the mitral dome into the left ventricle suddenly stops. A sudden stoppage, sudden tensing, that is responsible for opening snap. And this opening snap is best audible at the apex. Okay, it is best audible at apex, and this is actually best audible using the diaphragm. Okay, using the diaphragm of the stethoscope, you can best auscultate the opening snap. Now let me just compare a opening snap with the second heart sound. Okay, so let me just compare opening snap versus S2. Opening snap versus S2, a small comparison. Well, opening snap is actually occurring later. Okay, compared to S2, it actually occurs later, unless it actually there is a right bundle branch block that is actually present. So opening snap occurs later, and the opening snap is actually loudest at the apex. Okay, this is loudest at apex. Okay, whereas if you take S2, it is best heard at the cardiac base. Okay, so opening snap is loudest at the apex, whereas when you take the S2, best heard at the base. At the base of the heart. Okay, clear? Okay, now if a patient with a mitral stenosis has an opening snap, you can be sure of one thing, that the mitral valve is not very rigid and calcified. Because if you have a rigid calcified mitral valve, you are not going to get a opening snap. Okay, that sudden tensing will not actually happen because of a rigid calcified valve. So if you have opening snap, if you have an opening snap, be sure of one thing. If there is an opening snap, you can be sure that the mitral valve is not significantly rigid and calcified. Okay, it's not significantly rigid and calcified. Okay, all right. So which means, can I also say in this way, the opening snap is usually accompanied by a loud S1. Okay, opening snap has a loud S1. Yes, no? Because if you have a rigid calcified valve, you can have a soft S1. So opening snap is going to have a loud S1. Clear? Okay. Next point that you should know is that the opening snap, the mitral opening snap, okay, the mitral opening snap, it actually follows the A2 by a interval. Okay, it follows A2 by an interval of 0.04 to 0.12 seconds. So mitral opening snap follows A2 by a gap of 0.04 to 0.12. You will see in some textbooks 0.05 to 0.12, but more or less the same. So this is the the interval. So this interval A2 OS gap, this interval between A2 and opening snap, it varies inversely with the LA pressure. So this A2 OS interval varies inversely, very important, varies inversely, okay. This varies inversely with LA pressure. This varies inversely with LA pressure. So you tell me which will have a more severe MS, a shorter A2 OS interval or a longer A2 OS interval? A shorter A2 OS interval is again suggestive of more a severe MS. Okay, so shorter A2 OS interval again is associated with the severe MS. So we have discussed the three important auscultatory features of mitral stenosis. Let's see what are the other auscultatory features. In addition to what we have said, what are the other auscultatory features? Okay. So what happens is when the pulmonary arterial pressure increases, there can be a loud P2. Okay, when the pulmonary arterial pressure increases, there can be a loud P2. And again, if the pulmonary arterial pressure further increases, okay, it further increases, you can have a narrow split S2. The second heart sound will be narrowly split. And why does this happen is because one is the reduced compliance. Okay, there is a reduced compliance of pulmonary vascular bed. Okay, there is a reduced compliance of the pulmonary vascular bed in MS, and also there is an earlier pulmonic valve closure. Okay, there is an earlier pulmonic valve closure. Okay, whereas late stages, I told you there is a narrow split S2. Late stages you can have a single S2. Okay, late stages you can have a single S2. Okay, clear? All right. Now you can also have a non-valvular, okay, other auscultatory finding, non-valvular pulmonary ejection sound. Okay, non-valvular pulmonary ejection sound. Okay, now why does this non-valvular pulmonary ejection sound happens? This is again because of the dilatation of the pulmonary artery. Okay, because of the dilatation of pulmonary artery, and this non-valvular pulmonary ejection sound, what will happen with the inspiration, it will diminish during inspiration. Okay, very important. This will diminish during inspiration. All right. Okay, and also you can have a pansystolic murmur of a functional TR. I already told you, you can have development of a tricuspid regurgitation. So if the tricuspid regurgitation develops, you can have a pansystolic murmur. Okay, so it's a functional TR because there is no actual valve disease, it is a functional TR. And when the individual develops a functional TR, you tell me what is going to be the respiratory variation. This is going to be louder during inspiration. This is going to be louder during inspiration, and this diminishes during expiration. Diminishes during expiration. Now what is this called? A TR that becomes louder during inspiration and diminishes during expiration. This is called a Carvallo's sign. Okay, this is called a Carvallo's sign. Okay, this is called a Carvallo's sign. Very, very important. Okay, so I hope you are clear with that. And patients can also develop another murmur, that is, you can have a pulmonary regurgitation developing, and you can have a Graham-Steele murmur. Okay, Graham-Steele murmur of pulmonary regurgitation. You can have a Graham-Steele murmur of pulmonary regurgitation. And what sort of a murmur is a Graham-Steele murmur? It is a high-pitched diastolic decrescendo blowing murmur. Okay, this is a high-pitched diastolic decrescendo blowing murmur. Okay, blowing murmur. That is the Graham-Steele murmur of pulmonary regurgitation. And why does this happen? The pulmonary regurgitation, this actually happens because of the dilation of the pulmonary valve ring. Okay, so it is a result of the dilation of pulmonary valve ring. Okay, pulmonary valve ring, that is what results in the Graham-Steele murmur. Okay, so when you have a right ventricular hypertrophy also, you can have an S4 also happening, because there can be a RVH. Okay, suppose there is a RVH secondary to the pulmonary arterial hypertension. So you have the atrium that is contracting against a stiff compliant ventricle. So you can have a S4 that is originating from the right side. What about S3? Well, the S3 gallop, especially from the left ventricular side, is usually absent in case of MS. So S3, LV S3 is usually absent in case of mitral stenosis unless there is a significant mitral regurgitation or an aortic regurgitation that is coexisting. Okay, unless you have a coexistent aortic regurgitation or a mitral regurgitation. Okay, that's also clear. And these are the important auscultatory findings, we have discussed in detail. So just to highlight on one point, that is, patients with severe chronic MS, severe chronic mitral stenosis, they can develop something that is known as the mitral facies. Okay, they can go on to develop the mitral facies, which is nothing but the presence of some pinkish purple patches on the cheeks. Okay, pinkish purple patches on the cheeks. But in Indian population, it is very difficult to appreciate the mitral facies. Now, why does this happen? Is because of a low cardiac output. That is quite obvious. That is, this is occurring only in a severe MS. So, low cardiac output and systemic vasoconstriction. Okay, so that can result in what? The mitral facies. That can result in mitral facies. So this point also you should keep in your mind. Okay, so I hope you are clear with the examination findings in case of mitral stenosis.